is Shonda. I'm going to be the nurse practitioner. I'm going to be doing an exam of your musculoskeletal system today. Can you tell me your name and birthday while I wash my hands?
Deborah Booley,
And your birthday?
7/16/73.
Great. Are you having any pain anywhere today?
No.
Okay. First I'm going to begin the assessment by looking at her hands and fingers, looking for any redness, swelling, any deformities or anything. And then next I'm going to palpate the distal and proximal joints of her fingers, feeling for any nodules or swelling, which could be indicative of osteoarthritis or rheumatoid arthritis. Then I'm going to palpate her radial and ulnar heads, again assessing for any pain or swelling. And then I'm going to put her hands through range of motion. I'm going to have her flex her hand up. For the purpose of this video, I'm just going to do one side. Normally, for all of inspections and assessments, we check both sides. So she can just do her right hand for now. Flexion, extension, and then I'm going to do the range of motion adduction for her wrist. So you're going to take your hand away from your wrist, turn it outward. That's abduction, and then inward is adduction. And then for her fingers, again, abduction, have her open her fingers, and then adduction, bring her fingers together. Next, I'm going to be looking at her elbow. I'm going to just be inspecting, looking at the acromion process, which is the tip of the elbow, looking for any deformity, any redness, any swelling, and which I don't see any. And then I'm going to palpate the elbow, and then I'm going to palpate the inside, the lateral, and the medial aspect of the elbow, feeling for any pain, tenderness, which she doesn't have. And then we're going to do range of motion of the elbow, which again, flexion, extension, when she has no pain, and then supination, and then pronation, which, and again, she doesn't have any pain. The next area we're gonna assess is her shoulder. Again, I'm looking at her shoulders, making sure they're symmetric, making sure that she doesn't have a dislocated shoulder. One of her shoulders would be hanging if she had a dislocation, so I'm just making sure they're no swelling, no redness, and that they're symmetrical. Next, I'm going to palpate the shoulder. My hands are a little cold. I'm going to find the suprasternal notch, and then I'm going to laterally walk my fingers over to along the clavicle to the acromion process. And I'm going to palpate, and there's a little ridge, the acromion something joint, I don't remember the name of it, and feeling for the corticoid process. Oh, sorry. I guess I'm palpating too hard. And look for the little ridge, which is that joint, the AC joint. Next, I'm going to move down to the deltoid pectoral groove, which is here, I do believe, and then the lesser and greater tubercle, and then palpate the biceptal groove, which there's no swelling, there's no tenderness noted. And now we're going to do range of motion of the shoulders. Again, flexion, her arm's going to go up, and then it's going to, she's going to stand up. I think if you stand up, you can do it better. She'll raise her arm up, and then extension as she puts it behind her. What else compares metrical? And then adduction, again, and abduction. So she's gonna bring her arm up, and that's abduction, I'm sorry, with the B, and then adduction, she's gonna take her arm across her body. That's adduction, that's the range of motion for the shoulder. And there are a lot of tests, you can relax now. There are a lot of tests we can perform to test for any rotator cuff injury or tear. For now, we're just gonna do the speed test, which I'm gonna have her put her arms out. I'm gonna press against her palm, and as I press, she's gonna resist me. And do you have any pain in her? And she has no pain, so she has no rotator cuff injury. Next, we're gonna check the spine, which begins looking at the C7. We're just inspecting again, making sure there's no swelling, no redness. The posterior part of her neck, that's C7. And then I'm gonna check the anterior part of her neck, just looking for, again, symmetry, making sure her trachea is midline, which it is. Next, I'm going to have her do range of motion. You're gonna turn around the other way, of her neck. Flexion, which is the chin to chest. And then extension is her looking up at the ceiling. And internal cervical rotation. So she's gonna look to the right. You're gonna put your neck down, regular. Look to the right, look to the left. And then the lateral bend where she touches her right ear to the right shoulder, and then left ear to the left shoulder. And now we're gonna inspect her spine. Have her turn around again. And again, it's inspecting, making sure that there's nothing out of the ordinary, no swelling, that it's symmetrical. And looking at the curvature of the spine, the cervical spine should be concave, the lumbar spine, the thoracic part should be convex, and then the lumbar spine should be concave as well. So the spine should be like an S curve. I'm gonna palpate the C7 and then walk my fingers down each vertebra of the spine, checking for any pain, any tenderness, and any spasms or anything, and also checking for this step-off sign, which would be where a vertebrae is depressed in or sticking out, which I'm not feeling any of that. The next part is the range of motion, which for the spine, it's flexion, where she's gonna bend down and try and touch her toes. And again, I'm making sure she has the S curve in her spine, and then have her stand up and then extend back a little. That's flexion and extension of the spine. Twisting, she's gonna twist to the left, right, twist to the left, and then again she's gonna do the lateral bend where she bends to the right and bends to the left. Okay, the next body part there are the hips. So I'm gonna have her sit down, actually lay down while I look. Now, if she was complaining of any pain in the hip, we would have her, of course, we'd have the patient undress so we can take a look at the hip and see if there was any abnormalities in the hips, any swelling or anything like that. And we're going to do range of motion of the hip after I've inspected, and they seem symmetrical and everything. So for flexion, she's gonna lift her leg up, and extension, she would put her leg behind her, but I'm gonna have her on her stomach or her side and roll over on her stomach.
Stomach?
Stomach, yeah. And then you lift her foot up. And then she'll lift her leg up. Like,
Oh, God.
okay, so she lifted her leg up. Okay, and now we're going to have her on her side, on this side. Yeah, like that. Ooh, roll over so you don't fall. And I'm going to palpate the hip. I'm going to find the ACEs, which is the anterior superior iliac spine, and then the greater trochanter, and find her ischial tuberosity, which is the butt bone, and in between there I'll find the sciatic notch where the sciatic nerve is, and kind of just palpate lightly to see if she has a history of sciatic pain, which she doesn't have. And then we would also palpate or look at the SI joints, the back of the spine, the base of the spine, which should be in normal healthy people, they would be little dimples in the back, which I feel, and I would see if she was in a hospital gown. Next, we're going to have her sit up, and I'm going to look at her knees. And again, inspecting. I'm going to kneel down because my back is hurting. So I'd be inspecting the knees again, looking for any bruising, any redness, any swelling, which could be either infection, injury, or effusion. Hands are cold. I'm going to palpate the medial aspect, sorry, it tickles her, surface of the knee, and the patellar groove, and the tibial tuberosity, and then I'm going to check the lateral and medial meniscus to see if there's any pain, which could be indicative of a meniscal tear. For the knee range of motion, she'd lay down again, because for that I think I'd have her bend her knee and do internal adduction and abduction. So I'd move her knee out, which is abduction, and in, which is adduction, and then she would sit down again, and then we'd flexion and extension. I think you stand up and then bend it, like flexion, and then behind you would be extension. Yeah. And have her sit again. We're going to inspect the ankle and the foot. Oh, the back of her knee, I would be checking the fossa for any cyst, which I don't feel. If there was a ball, it would be pretty prominent, and that would be indicative of a Baker's cyst. I could also check below the knee at the tibial tuberosity. If it was bulging or big, that could mean the patient may have a history of Osgood-Schlatter disease, which she doesn't have. Next, I'm going to look at her foot. Again, looking at it, inspecting it, making sure there's no redness of the tootsies, no swelling, and no deformities. And then I would check the NTP joint, which is of the greater toe, to see if she had any pain or swelling or tenderness that could be indicative of gout. Next, we're going to check again the phalanges, checking the phalanges. While I think about the other part I'm checking, I'm checking the phalanges, and then the major bone of the ankle, and then, which is I don't remember the name of lateral malleolus. And then the inside would be the medial malleolus. We again would check both sides. And then I check the arch of her foot for if it was flat. Make sure there's an arch in the foot. Because if she had a flat arch, that would be a problem and probably would cause back pain. And then we're going to do range of motion of the ankle. You can just turn your ankle in a circle, or we could do flexion, extension, or the circular motion of the ankle. No pain, no tenderness. And that concludes the musculoskeletal exam. Thank you.